So the clinical practice guidelines in reviewing the evidence suggests that both the CTS-6, which is easy to administer in the office and takes a matter of about 30 seconds, ultrasound, which can also be done at the point of care and is much less expensive than nerve conduction studies, and formal nerve conduction studies, all have essentially equal accuracy when it comes to making the diagnosis of carpal tunnel. We did not really recommend a difference between any of these three mechanisms, and consequently, CTS-6 is the least expensive and easiest to do. But all three modes of evaluating carpal tunnel are equally valid and have essentially the same accuracy. So if you're doing an injection that's under ultrasound, you're measuring carpal tunnel cross-sectional area on ultrasound. I mean, that's very good confirmative data. If you're not sure what's going on, but the patient has a positive CTS-6, you can use a point-of-care ultrasound or formal nerve conduction studies as a confirmatory test, but all three are essentially equivalent. Well, as far as we know, there's really bracing, splinting, activity modification, and then there's surgery, and not much in between has been shown to be effective. Corticosteroid injections are used very commonly to temporize symptoms, but what the literature shows is no consistent long-term benefit. In the short term, we do see consistent benefit, but at 1 year or 2 years, none of the studies have shown any long-term benefit. I think things have changed over time as surgeons have gone from doing a formal open carpal tunnel release to either mini-open or endoscopic techniques that are a lot less invasive and cause less soft tissue damage. Over time, the literature has come to show that there's really no difference in either short-term or long-term outcomes between a very small incision, mini-open carpal tunnel release or endoscopic carpal tunnel release. Both are very effective. It may be that endoscopic techniques are a little harder to utilize under local anesthesia, which has been the trend in hand surgery. But there is some emerging evidence that there may be a somewhat higher complication rate with endoscopic. However, when reviewing the evidence, it did not meet our criteria for inclusion in the CPG, so we did not include it as a formal recommendation.